Everybody for coming. This is the GETAC Stroke Committee, and what I'm doing is I'm doing a roll call by paper, and what I'd like you guys to do is put cell phone numbers and email and stuff. And dispensing with that, first up on our agenda, Jane, do you have any comments that you want to do first? Usually you're in here, but I didn't see your name up here at the front. No comments?
Oh, I do.
Okay.
You want to do item number 6 first?
Okay, item number 6 is discuss change of ownership implications to a facility that is designated as a stroke facility.
Correct. We've recognized that there have been a number of facilities that have gone through change of ownerships since the beginning of this fiscal year, which was September the 1st. The way designation works, designation does not transfer to the new owner. And this is true for trauma and it is true for stroke. But as far as for RAC protocols, there would not need to be any change in the transport protocols within the RACs, assuming that the facility intends to continue their designation or participate in the stroke program.
Okay, so if I understand, if a hospital changes ownership, they have to reapply for stroke designation with the state, but what you're saying is that there'll be a period of time where they have license to continue within the transport plan, or is it I don't understand the implications.
Okay. There had been questions that actually came up with trauma. We've not had this occur in a stroke facility yet. Okay. For what had happened is when several trauma facilities were purchased and bought out and they had a change of ownership, the designation did not transfer to the new owner. And so the question came up in a couple of the RACs, well, what do we do? Can we still use them as a trauma facility? And what happens is at the change of ownership, they go immediately into an active pursuit for trauma. And so there is no change per se at the RAC. As far as when the trauma facilities go through their process of survey and designating again, it could be 2 years on their part. It could be immediately. It's really dependent on the program.
So stroke designations don't have in pursuit.
I know, they do not. So what we have right now is that the protocols would not be changed in the RAC. If we get a letter from the facility saying, yes, we want to continue in the stroke program, we're going to be a designated facility, so forth and so on. And we're going to have to work with the facilities pretty much individually on this.
Is there a time limit?
A time limit on...
for how long they have till they have to get their own separate designation, like 6 months,
for
1
stroke.
year, 2 years?
I don't think we have that right at this moment.
Okay. Do you want a recommendation on a time limit? I mean, my assumption would be that just because a place changes ownership, it's not going to change the policies and procedures quickly.
That's probably correct. And we think that most facilities who have gone through this change of ownership would probably just turn around and if they have a current certification from either or, then we would just designate the facility based on that.
Okay.
That's what we're anticipating.
Any questions from the audience? Any questions up here?
When you say change of ownership, so is the new facility gonna, guarantee the same level protocols, procedures, and so forth, and what's in place to ensure that that happens within a timely period?
Well, we have spoken to the Joint Commission, and that certification remains in effect until the next certification time. So as far as for stroke, we're working off of the Joint Commission certification the way it is in rule right now, or DNV. And as far as a level, if it were a level 3, which would go through our state process, I'm not sure. I don't know how, I'm not sure I can answer your question with that right now.
I guess my question then becomes, if there is a policy in place that reflects the Joint Commission standards and so forth, that we say something that you have to fulfill this within a timely period that fits with whatever their requirements are, so that it's just not an open-ended thing.
So my thought is, what our committee might want to do is ask for clarification on this, legal clarification.
Okay.
Yeah, that's kind of open.
Other thoughts?
Okay.
So we'd like to officially ask for legal clarification on this point. Thank you.
Okay.
Next up is a stroke committee work group report on the Texas EMS stroke education program. Did you have no? I don't think we have a report today, right? Or,
we're in the process of a 2-year implementation into the program, and that's what we're working on, is to get things going that direction. It's going to be a period of time before it will actually take effect. 2 years.
okay.
So we're headed that way. It's just going to be a little slower than we had hoped.
Next up is the stroke committee work group report. We created 2 task force, splitting the committee in half, and then also got some help with some hospitals input on the request for us to review certification programs from DNV, Norske Vietas, and the Joint Commission. What we were asked to do was review if they met the state requirements for Comprehensive Stroke Center certification / designation using the Brain Attack Coalition's report from 2005. Those programs were sent out and reviewed, and we had conference calls and then also emails Monday looking at those 2 programs, and both task forces will want to recommend that both the DNV and the Joint Commission be approved as certification programs for comprehensive stroke centers. So at this point, it may be difficult for any public comments, and public comments weren't solicited, but my understanding from this point, our committee then will recommend to the General Counsel that these be accepted as certifications. Is that right?
Well, you have 6 folks here. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So you do have a quorum. Yes, you can move that through.
Okay.
It will go on to the council's August agenda.
Right,
Okay.
right. So I would like to move that both DNV and Joint Commission be accepted for state designation. Any opposed? Seeing none, we'll make that. That's approved. Since you have sitting up here a lot of people that have looked at this, if there's anyone in the audience that would like to ask questions about the DNV or Joint Commission certification process, we may be able to answer some of those for you. So basically they're very similar. There's some minor difference in the metrics between the two, but the metrics aren't really part of our designation process. They're all, I mean, they were amazingly similar between the two. Okay. Next up is an update on the Texas Cardiovascular Disease and Stroke database. I wasn't able to go to that meeting, but we received letters back from the council from the Department of Health Services in that the Department of State Health Services does not want a stroke registry, and that it doesn't fall within, they do not believe it falls within the legal construct that they're working right now. However, we've not asked for a stroke registry. We've asked for a collection of database information without public health information that's already published to just be assembled for a demographic overview of the state. So right now what the plan is to take that back and get clarification on that, because that wasn't exactly what we were requesting. Does anyone have any questions about that? Nope. And well, they felt, well, first of all, they were concerned about collection of public health information or individuals' names and things like that. A registry infers that you're going to continue to follow people from place to place, which has never been the intention. The intention was to collect the number of IV TPA therapies, the number of intra-arterial therapies, and home disposition, which is what hospitals have to give out anyway. Then the other issue was the monies, how much it costs personnel to do it, and what else? Yeah, sharing patient-level data, which is not confidential patient-level data, which is not part of this at all. So we'll see how that works out. But right now, the DSHS doesn't want us to pursue that further. Just a straw poll, do people here believe that it would be useful to have demographic information about treatment of strokes in the state? Yeah, I see a lot of hands. Yeah, I mean, I don't know how you marshal resources otherwise. There are obviously places that need help and other places that don't.
Now can you hear me? Okay. Never mind, changed my mind, no. The only way that stroke is going to grow in the state of Texas is to get data points, to get data where we know where the problems are, where we know where stroke care is falling short in areas of the state, and we have to have data to do this and in a central database. It's not a registry where you have to put any kind of patient identifiers or anything like that. We just need some data so we can grow.
Yes, please.
I wasn't planning on saying anything, but I'm Daryl Pyle from SETRAC in Houston. One of our most active committees, enthusiastic committees, is the Stroke Committee. And in fact, all the hospitals that are expected to turn in data to the Stroke Committee, we had 100% compliance this past quarter. And this has lots of momentum, and I want to congratulate you for staying focused on it, despite what you might have heard regarding creating a registry of some sort. Let's at least collect the data. I've now been asked to contact some of the other RACs so that we can compare data among our RACs. I think this needs to be a formal process, and I think that with the graying of America, this is a topic that, of course, we need to study, and we're naive not to. Thank you.
Can I have a follow-up question? Would it be possible for someone from SATRAC, is it SATRAC or the Houston? Yeah, from SATRAC. Yeah, to do a presentation on what they've done,
Yes.
or the data?
Certainly.
Maybe I think our next meeting is August. So that would be wonderful.
Good.
Okay, thanks.
Maybe I'm a little slow. I'm missing the registry versus just collecting the data points.
Right, okay. Technically, you know, when you start getting into legal terms, registry has implications that a database does not.
Okay.
A registry follows individual patients, and it may follow them over time from hospital to hospital setting. It has a whole different meaning than just a generalized database. A database just means information.
So to gather the data, like she was saying, I mean, there's no implications relative to patient privacy or following the patients.
Yeah,
So-
PHI, correct.
And we can gather that information, and that's what he's saying. Is that, am I understanding?
Well, it's
that?
being done at a RAC level.
Okay.
It's just
Okay.
that I believe, and obviously other people believe as well, that having it on a state level would be valuable too. For example, let's say one RAC is not doing as well as some of the others, then resources could be marshaled to them to help them. Or education programs or other things. And from a state standpoint, to me, that seems important.
I'm the rookie here, so I'm trying to.
No, it's,
So we are doing that, or we're trying to ask them
So-
to take this data?
some RACs are doing this. We have pushed to do this on a statewide
So
basis.
can we follow up with that recommendation, or we made that recommendation?
Yeah, we have made this committee has made recommendation on what data points need to be collected. That went to a different council, the Texas Council of Cardiovascular Disease and Stroke, which is a part of the Department of State Health Services. That committee, that's what they are charged to do, is collect that type of information. And that committee made a request to do that, and the state is balking at that because they're not sure because it wasn't clear what the request was. But there are legal considerations, and if you represent the Department of State Health Services, you know, you also have to do what's legislated. You have to also do that with money and resources, and so there are all sorts of implications.
I think it would be useful to know which RACs are collecting data already and which ones aren't, just an effort to support our recommendation. 'Cause I'm a part of the Houston RAC as well, and I know we collect the data, but I don't know how many other RACs do.
Can you speak into the microphone, please?
And
I just said I think it would be useful to know which racks are already collecting data aside from the Houston one, because I think if many racks are already doing it, that would also support our recommendation.
and maybe that would be a way to ask for what racks are doing that, and collect that and send that up and say, geez, we're already
We're already
doing
doing it, yeah.
Yeah, so we need you other three to step up and
So I think most of the recs are doing some sort of data collection, but I would be surprised if all 22 of us collect the exact same data points, because I wasn't even aware y'all had developed data points to even get cardiovascular to review. And I'm at Waco Rack, and we've been collecting data.
Yeah, it was based on a hospital basis, you know, per stroke center, not on a rack basis. But the racks are collecting in feedback too. I mean, we could do a survey of the racks. Is that your suggestion or
That would be-
motion?
That would be my recommendation, that we survey each rack to see if they are collecting data, what points they're collecting, and what the compliance rate is of the hospitals in their system.
and to show the ones that are.
Yeah.
You know what? We can help you. We have an organization of the racks where we can actually pull that survey together and find out who's studying this, what are they studying, and bring that data to you if you like.
That would be great.
I think that'd be
Volunteer is
great.
accepted.
Yeah,
If
if
that
we could,
means name and
would that be
email address.
feasible for the August meeting, do you think?
Sure.
Because that would be great.
That'd be great.
Dr. Rutledge, I have a
Yes.
question. Have you identified what other, because it says that you can, the collection of some data from existing sources. So have you identified which existing sources you would want data from?
Yeah.
Maybe that's part of it.
Right. Actually, I don't remember the name of it, but hospitals have to submit, their admissions and discharges.
Discharge data?
Right,
Mm-hmm.
right. And I forgot the name of the place that they submit that to.
It's vital statistics.
But yeah, something like
Mhm.
that. And so it's a component of that. And and I guess the really sad thing is, all this stuff can be automated now in computer programs so that there's not, an epidemiologist isn't required to spend hours doing this. The data can go in and be automated and develop maps and all that beautiful stuff to look at.
Do you, Tammy, are you still here? No. Okay. Do you know, have you identified what data points you would want to see?
Yes, both this committee, I think twice, and the TCCVDS once has put those together. What they wanted was, or what's been requested is the number of stroke patients that received IV TPA as a percentage of stroke patients, the percentage of patients versus number of stroke patients that received endovascular work, and then the discharge of them. Did they go to skilled nursing home, rehab, which is a code.
Just a disposition.
Yeah, which is a disposition code. And the other request was the data points and get with the guidelines. But that was requested as not drilled down in data, but just meeting the percentages of get with the guidelines, which I probably have this wrong, but I think it's like 90, on the individual elements, it's meeting 90%. For example, one would be education regarding smoking cessation for your stroke patients. And I think get with the guideline, it's something like the threshold is trying to meet 90% or something. So it was just, did they meet, are the hospitals meeting those? And almost everyone is, because if they're getting certified, of course, they're meeting it.
If the information is collected in hospital discharge data, and I don't know about TPA. I'm really not that familiar with that information. But if it's collected there, you can request it back out. It's just a simple request of data that I believe they would give you. Now,
Yeah,
I
it may
don't.
be just a matter of clarifying this.
Yes.
And drilling back down that we're not requesting a registry.
Okay.
No? Okay, any other comments on this? Did you want to make a comment?
My name is Monty Waters, and I'm an attorney with the Department of State Health Services. My name is Monty Waters, and I'm an attorney with the Department of State Health Services. I'm the one who wrote the legal opinion that caused so much problem. Sorry for the misunderstanding about the meaning of the word registry. But just to clarify, the Cardiovascular Disease Council is authorized by its statute to collect information, and I'm quoting from their statute. They may use information available from other sources, such as the Behavioral Risk Factor Surveillance System and reports of hospital discharge data, that's what we've been talking about, and information included in death certificates. And the statute also contemplates you getting some information that may be considered confidential. I think in that hospital discharge data, they're very sensitive about hospitals, comparing different complication rates between hospitals. So some of the information on the facilities themselves may be confidential, but you're still authorized to receive it under your statute. So I think that's the kind of thing you're talking about.
Well, maybe we can talk later about your opinion.
Yes,
Okay, that'd be great.
thank you.
Because, that's the way I interpret it too. Other comments? Moving on, do we have any reports from liaison committees from the previous meeting, GETAC meeting? No?
I've got a few, but you'll have to give me a moment to read because
Okay.
The trauma committee reviewed the recommendation criteria for geriatric and pediatric populations. A work group was formed to review these recommendations and present a final draft at this month's meetings. Let's see what else is coming. Pediatrics. Trauma defined a pediatric patient as less than 15 years of age, agreed with this age for research and statistical purposes. Pediatric Airway Project is continuing. Medical directors received an update from Kathy Perkins on the Medicare fraud issue. There was a mention of an online medical director's course that's kind of in the process, I believe. The EMS group was also brought an update on the Medicare fraud issues. They discussed issues such as shady practices that are being used to obtain an EMS agency provider license. Discussed air versus ground transport issues, licensing authority. At a joint meeting, they had a presentation on differences in National Registry certification and Texas certification. Requested a report from DSHS on who is using which certification process. The education group discussed some clinical site issues and decided to survey the RACs in the future to get some information for this. The disaster group had an EMTF update. They advised 4 buses are in place now. By July, there will be 13 in Texas with at least 1 in each area, EMTF area. Strike team development is slow due to discussion of liability concerns. Cardiac committee reviewed presentations from the national meeting, which was an analysis of 23,000 STEMI patients. The solid numbers that pre-hospital, the pre-hospital treatment decreased M&M. They were also going to visit with the RACs about best practices acts and so forth. That's all I've got.
Okay,
Just some notes.
thank you. Yeah, I have a brief presentation on endovascular treatment, but what I thought I might do first is to try to get anyone out of here as quickly as possible and not listen to me droning on. So let's do general public comments first. Are there any general public comments?
My name is Remy Morris. I'm coming as Remy Morris, not an employee of anyone. I would like the minutes to show that there was a survey request made. It was unclear to me as who would run the survey, who would compile it, and who would report on it. And I think that needs to be clarified before the meeting ends, just from previous survey experience with GETAC and the Department of State Health Services.
So are you talking about the RAC survey? Um,
I have several hats to wear, and I'm also the representative for the RACs. Daryl Pyle.
Just because there's participant surveys that we ran a survey a few years ago that still hasn't been reported out, and that was a survey about where are the RAC with knee building, and so as far as stroke is concerned, so it's good news to me.
And Daryl, how do you spell your last name?
And he represents the Houston RAC?
Correct.
Okay. Can we put that into the record? I think that's
Yes.
what she's asking.
Got it.
You're asking for that to be in the record, right?
And you actually bring up an interesting report thing, Remy. That survey did that come through this committee, or was that through the TCCVDS? Was the medical directors or the RAC survey?
Jane might help me out on the memory, but my understanding is that it started here, and then it was done by the Department of State Health Services over at the CVD and stroke shop, not here. And then it's still to be compiled. It is compiled, but it's not approved for dissemination.
Okay, sort of, kind of. Flip some of that around. I think the original thought from it came out of CVD Council, then came here, then went through GETAC, through the council, and the council asked the RACs to participate in it. Then the survey was developed over in CVD. It was distributed to the RACs responded, and I do have an update on it. I actually told you last time I would tell you where it was. And the survey was conducted for cardiac and stroke systems of care. The data from this survey has been cleaned, tabulated, and graphed out by question. We are in the process of analysis and reporting an estimate completion within the next 3 months unless there are unforeseen circumstances that preclude completion. And this was from Dr. Kalanges.
Was that the survey like literally 3 years ago? Because that data is not going to be current anymore.
October 2010.
And that's ready in 3 months?
Well, I guess, can we make a request that it be presented at the next meeting if the winds are good?
I will relay that.
And granted, it'll be old, but it's a benchmark.
That's true.
If there's a question where Daryl might could ask the similar questions on his news.
It was you know, I'm always personally a little remiss of asking people to do too much work. The initial thing was, it was multiple pages, wasn't it? Like 10, 15 pages?
There was nothing about data collection in it.
Right. No, about redoing the survey. Let's get the first survey back, and then we can look to see if we want to do another one or repeat it as a benchmark. Those are great comments. Any other general comments from the floor, public comments?
So Dr. Rutledge, I'm sorry to be a pain. But
You're not.
So what is Daryl going to ask all the recs then if we haven't received, we haven't received the first survey information back? And so we don't want to ask the new stuff because we don't know. But if we're going to turn around and maybe ask the recs in August, then maybe Daryl shouldn't ask his question other than at RAC chairs tonight where we just say, yes, we're going to PI.
What Daryl was going to do was, in Houston, they're collecting data, and he was going to check to see what other RACs were collecting data and was going to do a presentation of the Houston's data. The RAC surveyed things like transport plans. Do you have a transport plan? What is your transport plan? How are you doing bypasses? It was a different sort of survey. That's my memory. Anybody else comment? Yeah, sure.
I would say we should suggest specifically what Daryl should be asking the RACs today, so we know what kind of answers we're going to get in August. So I think this is, at least what I was thinking, was just a very general survey to kind of help us recommend that GETAC recommends on a national, state level that we do this. So I think the 3 important things are to ask each RAC, are you collecting data, period? And then the next question will be, what are the data points you are collecting, just so we know what different people are looking at. And the third would be, what percentage of your hospitals actually are compliant with submitting data to you on whatever time basis you require.
And
Those
this-
would be the 3 main points we'd be interested in.
And this goes with what they supposedly did before?
What do you mean?
The previous survey.
Yeah.
No, I think this is
No,
very
the
different.
previous survey, the previous survey that was done to the RACs was evaluation of transport plans and general questions of that nature. It wasn't collecting data.
Okay, but we don't have that information.
It's in the process of being completed.
And it's 2 years
2 years old.
old.
But I think these are 2 different surveys.
Oh, okay.
So I think,
But that's going to come on the next meeting.
That's what
we've
we're requesting.
requested.
Okay,
yeah.
all right.
It'll be all facilities, right?
All,
You said, what are they collecting from their facilities?
Yes,
It
not,
should be all not stroke designated facilities because we're still in that whole support stroke center.
yes. So of the facilities that you request data, how many are actually submitting it? That would be very helpful. Thank you.
Thank you.
thanks, Daryl.
Thank you very much.
You gotta go start.
So everybody's square? Okay. Any other public comments? know if I can get help from someone on the little computer over there to advance slides every once in a while. But what I wanted to do is just show you, just showboat a little of what endovascular therapy looks like. And in the Seton system, we've been a part of most of the major endovascular trials, and this is sort of a follow-up to the SWIFT trial, which was just completed. And this is, I'm going to start out with just sort of a case example and then show you the trial results. This is a patient about a week and a half or 2 weeks ago. It's a 64-year-old male who presented to Seton Medical Center at about 1:30 in the afternoon. He was last seen normal at 8 a.m. when his partner had left. He had a stroke scale of 14, and because of his time of onset was not known, it was longer than 4.5 hours, he was not considered an IV TPA candidate. At our facility, we start out with a CT scan right here, and you can see that he has an old stroke right there, which actually affected his hearing. And the CTA scan, or the CT angiogram that was done concomitantly with this, shows an area right here of a thrombus in the left middle cerebral artery. And this accounted for him not being able to speak and not being able to move the right side of his body. So if you could advance to the next slide. So we also do perfusion imaging at our hospital, and if you haven't seen perfusion imaging before, these are colored maps showing sort of the status of contrast getting to the brain over 40 seconds. And this first image is a time to peak image, and the red areas here are areas where blood is not getting to that part of the brain quickly. It's a delayed blood flow to that part of the brain. And then on the other image on the other side, this color image here, what this shows is this is a cerebral blood volume image, and it shows that there's not much blood getting to that area of the previous stroke that you saw, but all this red area here, there's still blood flow getting to that area over 40 seconds. So what this tells me is that this wasn't a completed stroke. If you don't have blood flow to an area over 40 seconds, that can be a sign of futility that that area is not going to reperfuse. So you hit the next slide. So this patient was taken to the neurovascular lab, and an arteriogram was done, and this is a picture looking in the AP projection, sort of looking right at their face. And you can see that the internal carotid artery comes up, and the middle cerebral artery right here stops. And because of that, that's why there's delayed flow here, and that's actually why this patient is having their ischemic symptoms. Well, the solitaire device, which is one of many of the stent on the stick devices, it's a little like a Chinese wire finger toy with another wire that's attached to it. You can put this up and cross the area of the blood clot and expand this little spring device, and that's what was done in this patient. And you can see that there's the clot right there, but you can see the blood vessels are open. This took, from the time the arteriogram started to the time of opening up this blood flow right here, took 14 minutes, which is amazingly fast. Previously, we used devices like the Mercy device, which was like a little corkscrew where we would pull clots out of the blood vessel, and it might take several passes of pulling it out to pull the clot out, and it would take an hour and 15 minutes. If it took as long as 2 hours, you would pretty much stop. So the idea that you can restore blood flow in 14 minutes is, to me, amazing. If you do the next picture. So this is what this particular device, this stent on a stick, looks like. It's sort of this chicken mesh in a cylinder that crosses the blood clot here. And what that does is it opens up a channel to immediately restore blood flow. And then when you cinch it back and you pull it back, it grabs the clot and, or any residual clot, and you can pull it back out. And this is a follow-up arteriogram on this gentleman 14 minutes after the device was put in. And he completely returned to normal. His NIH stroke scale actually returned to a level 3, but that was because he had his previous underlying stroke, and he was discharged 3 days after this. So if you go to the next slide. So to just tell you about this SWIFT trial, we were one of the, I think there are like 10 or 12 places that were involved in this. Basically, the inclusion criteria was 22 to 85 with moderate to severe strokes with NIH stroke scales 8 to 30. The requirement was that you basically had to have a vessel occlusion. And that's a TICI or TIMI score, where it's describing how much of the blood vessels are stopped up. They had to be treated within 8 hours. They had to be ineligible for TPA or to have failed TPA. That is, you give them TPA, and after an hour, if they're not getting better, they could then proceed with this type of procedure. And they had to be able to be willing to be involved in follow-up studies. So next. Exclusion criteria was basically NIH stroke scales over 30, obviously people who aren't going to get better. If you were rapidly improving, or if you were pregnant, or if you were allergic to contrast, or if you were in another study, if you couldn't control their blood pressure, if they were on anticoagulants, if they were hypoglycemic or low platelets, or if you couldn't get the catheter there, or if they weren't expected to live for 90 days. There were also imaging exclusions if they already had a big hemorrhage, or if there was signs of futility, if they had edema on the non-contrast CT, the same criteria as the NIND